Yes, yeah.
Good afternoon. So hopefully I can get through some of this. We catch up some time here.
Thank you.
So in essence, I'm going to be debating against Dr. Rao, who's a cardiologist that you've heard probably in numerous symposia. He just spoke in the morning session, and he will be talking about endovascular and in such a way that it'll still be the first-line treatment for CLTI. Here are my disclosures. So essentially, what we should probably start with is the truth, that the best CLI data is prospective randomized level 1 data that's kind of founded on the fact that a suitable single segment great saphenous vein with open bypass is superior to endo. There's a lower incidence of major adverse limb events and death with the statistics that are supporting that fact there, with fewer major amputations, lower rate of major reinterventions, and you know, that's kind of where we start. So I'm not really sure how Sid's going to approach this. There's been a lot of different debates since this data came out. I don't think anybody is shocked, or I hope this isn't news to anybody. But that being what it is, I'll kind of carry on here and say that one of the biggest issues with this argument is that we really don't know what best endovascular means for CLTI. We spent all morning actually looking at live cases and looking at data. Is it antegrade? Is it retrograde? Is it up and over? Is it atherectomy? Yada, yada, yada. And even, I don't think there was a single one of us in the session this morning that would have done it precisely the way that Dr. Raja did it, or you know, Dr. Ramaiah does it. It's just, it's such a vast ocean of variability that it's almost impossible and kind of ludicrous, frankly, to expect that this is going to be something that's going to be smoothed out anytime soon, as opposed to a bypass, which is saphenous vein, in situ or reversed, using 6 or 7-0 proline and 2 wounds. That's it. So it's much more streamlined, it's much more simple, and so I think that's how we got to the data. And you can argue it on and on and on here about technical failures in the endo part and early reinterventions with the endo. Maybe there weren't fancy technical nuances such as drug-eluting technologies. But even with level 1 data, with drug-eluting stents, it's not really hitting that hard in terms of the garden variety vascular specialist. How is it that we have level 1 data that says that one device is clearly superior to the other, yet if you look at the data here from 2024, that really hasn't affected the usage patterns. Even worse, if you look at just the data of drug-eluting technologies in the stent realm, and then just kind of the hodgepodge of utilization patterns, none of this makes me think, oh yeah, this is guided by class 1 evidence. And if you think that that's the case, then you're severely misinformed. So, you know, my hat's off to Craig Walker. I consider him a mentor and a true master at endovascular therapy. So I'm not talking to anybody in this room because everyone here has dedicated themselves in one form or another to vascular specialists, we'll just call it that, treatment of our patients. I'm talking to the potential dabblers and other people that may not be completely dedicated to this therapy. But when Dr. Walker comes in and states clearly that there are huge flaws to the study, I respect that. I do respect that. But be that as it may, it is the evidence. And so, again, assuming that we actually care about level 1 evidence, which we should, because it should influence the clinical practice guidelines and the decision making, it's kind of the end of the debate. That's it. You know, I think it's not feasible for us to kind of just blanket statement endo first strategy with the overwhelming factual evidence of what this is. Clearly, I think everyone knows, and we started the conference today with the idea of a multidisciplinary team approach and shared decision-making with our patients. Ultimately, if you think about what's happening in the real world, well, we know that a saphenous vein needs to be evaluated, but there's not that many people actually looking at the saphenous vein. With this study here just recently saying 76% of patients didn't even undergo an ultrasound to look at the saphenous vein. So how are we saying that we're caring about class 1 evidence when the behaviors aren't following? This is not news. Again, looking at the majority of patients in an interventional realm are claudicants. Again, I'm not talking to anybody here. Clearly, you all are doing CLTI and whatnot, but the garden variety strip mall person is probably just doing claudicants. And this may have a lot to do with referral patterns and also with the type of disease that's treated. Many of the primary care physicians in the best interests of their patients, to their knowledge, intuitively think it's better for us not to have my 80-year-old grandma come in and get a femdistal bypass. I'm going to send it to Dr. So-and-so that says that they do a lot of this endo stuff, whatever that means. And then the real grim and grimy stuff about payment and how that might drag our decision-making down for a fee-for-service model, which unfortunately is the norm. It's very difficult to tease that apart, especially when you see these grim New York Times articles making the accusations that we all are aware of. There's newer paradigms, such as bundle payment programs that may change this, which may change the incentivism, gain sharing, which is kind of a relatively new thing, and then, of course, the pay for performance, which many claim is going to be the future, which is not really the scope of this talk. But I think there is a lot of changes happening, but at the very least, we need to be looking at tracking things like saphenous vein mapping to see if we're really applying these to our daily practice and asking ourselves, are we really thinking about level 1 evidence? Because we do have it in peripheral vascular, and I'm not convinced that that's a big thing in our day-to-day affairs. And then what doesn't really go into the papers is how reduced reinterventions and amputations with surgery may lead to an improved quality of life for our patients. So with that, I'll have Sid come in and prove me wrong.
Thank you, Dr. Henao.